And with this, we will have to invite Dr. Alberto Feletti from Verona. He is an associate professor of neurosurgery in University of Verona, and he will be talking today on endoscopic anatomy of the brain ventricles. Dr. Alberto, please share your slides. Yeah, you're visible.
Yeah. So thank you to the organizer. Thank you to the moderators for having me. Well, after hearing the amazing presentation about the microsurgical anatomy of the ventricles, of course, my duty is easier to explain and to describe the anatomy from an endoscopic point of view. Some of you might wonder, why should we talk about microscopic anatomy and endoscopic anatomy of the ventricles? After all, the anatomy is always the same, and it is actually, the anatomy doesn't change. But depending on the way we are approaching the ventricles, the perspective on the anatomy does change, as we will see soon. Well, no need to spend time talking about the structure of the ventricular system, as we have already talked about that. But I want to start with this question. We can wonder how many structures are named within the ventricular system. Well, I don't think there is a precise number, but some anatomists guess that there are really a lot of structures that can be identified inside the ventricular system. But the real question for us as neurosurgeons is how many structures we should know for performing a safe endoscopic procedure. This is the main question, and this is the aim of my talk today. I want to mention briefly about the history of the anatomy of the ventricles. And if we talk about the history of the research on the anatomy, we have to mention Andreas Vesalius, one of the giants of the here close by Verona, actually in Padova, which is my alma mater. And you can see the old anatomical theater, the wood anatomical theater, which is the oldest in the world, in Padova. And this is a page of this De Humani Corporis Fabrica. Please know that it was written in details of this drawing of the lateral ventricles. It's amazing how at that time Andreas Vesalius was able to precisely draw the shape, not only the shape actually of the ventricles, which is amazing enough because at that time the anatomy could be studied only on cadavers, and we all know that on cadaverical specimens the brain collapses as well as the ventricles, so guessing the real shape of the ventricles was not easy at that time. But he also drew, as you can see, the choroid plexus exactly as they are. Compare the anatomy from the Roton drawings with these drawings. It's amazing for the time. So nowadays we are able to see this anatomy from inside and in vivo through a small bar hole, which is usually placed in the frontal area of the skull. We can obviously use rigid scopes, but also flexible scopes. And what I'm going to show you today is the anatomy seen from a flexible endoscopy perspective. Why? Because with the flexible endoscope, it's possible to explore virtually every corner of the ventricular system, even the fourth ventricle. So we have a quite good experience in doing this, more than 1,000 procedures. My personal series is about 200 of these procedures. And so I was able to collect many videos and pictures, and we published also many of them. So just a quick look on the journey, neuroendoscopic journey within the ventricular system. This is the endoscope entering through the pili way the right lateral ventricle. and this is the choroid plexus. We have seen the choroid plexus already. This is the Monro foramen, and then we can enter the third ventricle, a nice view of the mammillary bodies and the tuber cinereum, and then we can bend the tip of the flexible scope to the posterior part of the third ventricle. This is the adductus of the cerebral aqueduct with the posterior commissure, the habenular commissure. This is the pineal recess between the two commissures, and in selected cases, of course, only if it is clinically relevant, we can navigate through the cerebral aqueduct. This leads us to the fourth ventricle. As we can see here, there is the cerebellum covered by the choroid plexus and the floor, which is at the top of the screen. So this is possible using a flexible scope, which has a diameter of either 3.9 or 2.8 millimeters. But let's have a look on some details about what we can see with an endoscope. Well, the previous presentation already showed a lot of this anatomy, so I will go fast on this. If we want to draw the structures that we see from an endoscopic point of view, of course, we have to draw the lateral parts of the lateral ventricle and the floor of the lateral ventricle, and also the medial part. So let's start with from lateral to medial. So the most lateral structure that we can see is the caudate nucleus, which has this direction, as you can see from the arrow. And then we can go more medial, and more medial we can find the thalamus, which is here. Between the thalamus and the caudate nucleus, there is a sulcus, which is called the thalamus striate sulcus, and within this sulcus lies the thalamus striate vein. We have already seen that the thalamus striate vein points towards the Monro foramen, where it joins usually with the anterior caudate vein, which is not visible in this cadaveric specimen, and also with the septal vein, and they all contribute to form the internal cerebral vein, which runs on the roof of the third ventricle. We know that the thalamus is covered by a thin lamina, which is called the lamina affixa thalami. Actually, this explains the white color of the ependymal layer covering the thalamus compared to the other parts of the ventricle. And in particular, the part of the lamina fixa thalami, which is covering the thalamus striate sulcus, is called the lamina cornea, and this lamina cornea covers the thalamus striate vein, and this is the reason why the thalamus striate vein is very evident when it is close to the Monro foramen, but at a more distal part it appears opaque because it's actually covered by the lamina cornea. If we move more medially, we can find the choroid plexus, which is also pointing towards the Monro foramen, and again the vein of the choroid plexus and the tinea, which anchors the choroid plexus to the floor of the lateral ventricle. Moving more medially, we can find the fornix, the body of the fornix, and then the columns of the fornix, which are forming the Monro foramen. And finally, at the midline, we can find the septum pellucidum. So as you can see, the main structures of the lateral ventricle, as we can see with an endoscope, are arranged in a sagittal direction. This is very important because this arrangement helps us in orienting within the lateral ventricle. These are some images taken from Roton showing the anatomy that the previous talk has already shown. And this is the endoscopic perspective. So as you can see here in this video, we are looking at the Monro foramen with the columns of the fornix, and this is the fornix. This is the choroid plexus. This is the septal vein, and this is the thalamus striate vein. So let's move on. As you can see, the thalamus striate vein is covered by the lamina cornea, so it becomes more opaque distally. And we have always to remember that following the choroid plexus, it leads us to the Monro foramen. In this case, the septum pellucidum was disrupted, so we could explore also the contralateral lateral ventricle. This is the choroid plexus going to the atrium of the left lateral ventricle. Let's move to the third ventricle. So if we imagine to draw the third ventricle in a sagittal plane, we can draw it like this. So we can draw the anterior part of the third ventricle and the floor. Then there is the roof, of course, and this is the brainstem, in particular the mesencephalon, and above we have the fornix, of course, and we can localize around the third ventricle some very important structures which are actually visible during endoscopy of the third ventricle. One are the mammillary bodies on the floor of the third ventricle. Another one is the hypophysis. Another one is the pineal gland, which is under the pineal recess, below the pineal recess and the posterior part of the third ventricle. Then we can identify the optic chiasm, which is visible from inside the ventricle, as we will see. This is the adagio interthalamica, and this is the location of the anterior commissure, which is rarely, very rarely seen through a frontal bar hole because of the angle of vision. And here, the posterior commissure is located. The posterior commissure is a posterior limit of the adytum of the cerebral aqueduct. And just above the posterior commissure, we have the habenular commissure. And this is the Monro foramen through which we insert our endoscope. So let's see how the main structures that can be seen during endoscopy of the third ventricle are arranged. Let's start from anterior and moving to posterior part of the third ventricle. So the most commissure, as we have seen, just below the anterior commissure, there is the lamina terminalis, which actually lays between the anterior commissure and the optic chiasm. Again, if we move back from the optic chiasm, we can find the infundibulum. And just behind the infundibulum, we can identify the tuber cinereum with a very characteristic gray color. Just behind it, we can see the mammillary bodies that are visible also on this cadaveric specimen. And then we have a large part of the floor of the third ventricle, which we identified as tegmen mesencephaly, the tegmentum of the mesencephalon. And then we will find the adytum of the cerebral aqueduct. In this specimen, it is not possible to see because it's covered actually by the posterior commissure. And behind the posterior commissure, we have the habenular commissure. And between some of these structures, we can identify some recesses, like the optic recess, just anterior to the optic chiasm. The infundibulum, of course, it's a recess. And then the pineal recess. So as you can see, most of the structures of the third ventricle, as we can see them from above, so from an endoscopic point of view, are arranged in a transverse direction. Again, these are some images taken from Roton. I will not spend so much time on them. I will move directly to the endoscopic vision of the anatomy of the third ventricle. So here you can see a video of the navigation of the third ventricle, where you can see immediately the two mammillary bodies and the tuber cinereum in front of the mammillary bodies, which is the location of the third ventriculostomy, of course. And in front of the tuber cinereum, we can see the infundibulum, uh, and in front of the infundibulum, there is the optic chiasm, and this is the lamina terminalis. And between the optic chiasm and the lamina terminalis, we could see the optic recess. Now I am moving the scope all the way to the back. This is the tegmen of the mesencephalon, and posteriorly, the additum of the cerebral aqueduct appears. This is the posterior commissure, the abennular commissure, the pineal recess, the suprapineal recess, and we can even see the roof of the third ventricle with also the vision of the internal cerebral vein running on the roof of the third ventricle. So it's a very nice view with a flexible endoscope. I want just to point out your attention on the abennular commissure. It's an interesting story because, of course, it connects the abennular nuclei, which are at both sides, at both sides. And abennular comes from a Latin word, abena, which means rains. Actually, the abennular commissure looks like a small rain. So the ancient anatomists, the Latin anatomists have a really nice fantasy at that time. And starting from the abennular commissure, we can see the striae medullaris thalami, which are actually some fibers, some crests visible on the lateral part of the third ventricle. And inside we have fibers connecting the abennular nuclei with the thalamus. These are some pictures taken at the posterior part of the third ventricle, and this is actually a comparison between the normal anatomy with the anatomy in case of hydrocephalus. As you can see, in case of hydrocephalus, the anatomy is completely different. The normal anatomy of the additum of the cerebral aqueduct is triangular, with a thick posterior commissure and a normal abennular commissure. But look, in case of hydrocephalus, the additus becomes more rounded, and the commissures are very much stretched. I will not spend so much time about this because I think next speaker will talk about this topic. So let's move on. Again, we are inside the third ventricle. I'm showing you this case because we did operate this patient who had a recurrent ependymoma of the fourth ventricle in the prone position. And after the removal, with a microscope, of course, as the tumor was very bleedy, we inserted the flexible endoscope through the Magendie foramen up to the third ventricle, so in a reverse way, just to make sure that no blood clots were inside the third ventricle. So actually we found blood clots and we aspirated these blood clots inside the third ventricle. See, the blood clot is at the roof of the third ventricle, of course, because the patient was in the prone position. But why I'm showing you this case? Because this reverse navigation of the third ventricle allowed us to have a nice, very unusual look on the anterior, upper anterior part of the third ventricle, with both Magendie foramen and the anterior commissure, which is almost never seen during an endoscopy from the classical frontal bar hole. And this space between the columns of the fornix and the anterior commissure is called the triangular recess. Let's move to the anatomy of the cerebral aqueduct. The cerebral aqueduct can be divided in 5 parts. The adytum, the first and the second constriction. Between them, there is an enlargement called the ampulla, and finally the egressus. Let's see this video. This video shows very clearly these parts. So this is the adytum, as we have seen already. And as you can see, there are 2 constrictions, this, and between them, there is an enlargement, which is the ampulla. And actually, if you notice, there are some pulsations of the wall of the cerebral aqueduct. And this confirms that actually the cerebral aqueduct has a compliance to accommodate small, tiny, flexible endoscope. And finally, the egressus of the cerebral aqueduct. We have recently published this paper about morphometric model to try to guess if the navigation of the cerebral aqueduct with a flexible scope is safe or not. We basically draw a triangle including the adytum of the cerebral aqueduct and the posterior commissure, and we draw another triangle inside the first triangle, drawing a line at the posterior part of the cerebral aqueduct. And we notice that in the normal anatomy, the height of the first triangle is 1/3. And this height of this trapezoid is 2/3. But in cases of hydrocephalus, this ratio changes, enlarging widely the cerebral aqueduct. And this was also associated with the risk of having small contusions on the wall of the cerebral aqueduct. So this is, I think, very important because, as you know, when we are navigating the ventricles, we don't have any absolute measure. As if we get closer to a structure, the structure becomes bigger and vice versa. So we need some ratios to have an idea of the size of the structures. Let's move to the fourth ventricle. The previous speaker has shown nicely already the anatomy shown by Roton pictures. I will go fast. Here we can divide the floor of the fourth ventricle in 3 parts: the superior or pontine part, the intermediate or junctional part, and the inferior or medullary part. And this part includes the calamus scriptorius, which is a very fascinating area, as we will see. Here you have the median sulcus, and at both sides of the median sulcus, you have 2 crests called the median eminences. And as you can see, these eminences, the median eminences, at some points have some enlargements, like this part. We are talking about the facial colliculi, of course, but also down here we have the 2 triangles, the hypoglossal triangle, and down here the vagal triangle. And laterally to these median eminences, we can find another sulcus, which is the sulcus limitans. And also here we can find some specialized areas like the inferior and the superior fovea, and the locus ceruleus, which is the area of our brain producing norepinephrine. So we can move on here, move to actually the endoscopic vision of this anatomy of the floor of the fourth ventricle. We have described this anatomy many years ago, actually, and the pictures at that time were not so clear as nowadays, but still it was possible to show that with an endoscope, it is possible to visualize many of these structures, especially those in the intermediate and in the inferior triangle. You know, the amazing thing of endoscopy is that during endoscopy you don't deplete the fourth ventricle of CSF. So CSF is still there, and this is very important because the pressure of CSF enlarge the fourth ventricle and preserves the normal anatomy of the fourth ventricle. But during microsurgical approaches, this anatomy is somehow altered by the depletion of CSF. Also, the floor of the fourth ventricle is not a flat surface. It has some sulci, it has some crests, and the privilege of a vision through an endoscope is that the light is not coming from the front, but it's coming tangentially to the floor. And in this way, there is like a interplay between areas of light and areas of shadow. And this contrast of light makes these structures very evident. As we can see, even in these old pictures, we can see the facial colliculi very bright because they are hit by the light. We can see the medial sulcus. In some cases, in many cases, we can see also the triangles, but probably it's better to use the new endoscopes. Nowadays, we have also some endoscope with a chip on the tip. Not this case, but the vision is even better with those endoscopes. Here you can see the floor of the fourth ventricle and the facial colliculi here and here, the median sulcus. And if you go closer to the brainstem, very soon you will be able to see other structures like these ones. As you can see here, there are some horizontal crests that will become more evident soon. Here they are, here. Okay, these ones are the acoustic striae. And down here, we have the two triangles. In this video are not so clear, but we can have a very nice vision of the area of the calamus scriptorius, which is quite hidden during microscopic approaches to the posterior fossa, because there is a membrane down here, which is called the membrane of the obex, which obstructs the vision basically during microscopic approaches. And here you can see the Luschka, the right Luschka foramen, and the Magendie foramen is down here. And here we are moving laterally towards the left. There is a nice view of the tinea, which is connecting the choroid plexus to the floor of the fourth ventricle. And this is the choroid plexus going all the way towards the left Luschka foramen. A few words about the roof of the fourth ventricle. These are the anatomical specimens by Roton, but let's have a look on the endoscopic vision. So it's very interesting in this case to compare the normal anatomy, as you can see in this left picture, with the anatomy in case of hydrocephalus. So the normal anatomy shows some peculiarities, like when you are entering the fourth ventricle, you have to remember that the roof is at the down part, the bottom part of the screen. So in this way, you can see here a part, the upper part of the roof, which is the superior medullary velum. Like here, this is the superior medullary velum. And as you can see in the normal anatomy, the superior medullary velum has a convex shape. And laterally, we can find the superior cerebral pedunculus. If we go deeper in the fourth ventricle, we can see that the nodulus of the cerebellum and the tonsilla of the cerebellum are covered, almost completely covered by the choroid plexus. But if we have a look at the situation in case of hydrocephalus, we can notice that when we enter the fourth ventricle, the superior medullary velum is more flat. It's not convex anymore. And the choroid plexus are not covering completely the nodulus and the tonsilla, which become very, very clear. And here you can see also the picture of a comparison between the normal anatomy and the anatomy in case of hydrocephalus. The inferior medullary velum, which is this part here, doesn't change so much. Another privilege of exploring the fourth ventricle roof with a flexible endoscope is that you can actually see the landmarks for the telovelar approach, which are not so easy to visualize during a microscopic approach because they are covered by the uvula, by the cerebellum. But from inside, you can see very clearly the inferior medullary velum and the tinea, which anchors the choroid plexus to the roof of the fourth ventricle. This is a video showing the normal anatomy of the roof of the fourth ventricle. So let's move on. Here we are entering the fourth ventricle from the cerebral aqueduct, the superior medullary velum, which is convex, the superior cerebellar pedunculus. Here we can see the inferior medullary velum, the nodulus, tonsilla completely covered by the choroid plexus. And then we can move on. We can have a nice look of the Magendie foramen with the tinea connecting the choroid plexus to the floor of the fourth ventricle. And here we can see the pica, the caudal pole of the tonsilla, and this is the opening of the central medullary canal. This is another video of the same set of patients. So let's move on with a video about the anatomy in case of hydrocephalus. As you can see, when you are entering a hydrocephalic fourth ventricle, the superior medullary velum is not convex, is flat. And in this way, you can see much better the fastigium, which is not visible so easily in the normal anatomy. Here, you can see the inferior medullary velum, the choroid plexus, the tinea of the choroid plexus, and the tonsilla and the nodulus, which are not covered completely by the choroid plexus. And the lateral recess and the tinea, again, connecting the choroid plexus. As you can see here, the Luschka foramen is obstructed. So this also shows a obstructed Magendie foramen, and this explains the hydrocephalus of this patient. Let's move on to the calamus scriptorius, a very fascinating area, which is difficult to visualize during microsurgical operations, but very easy to be seen during endoscopic procedures. So these are some visions of the calamus scriptorius area. Look at this picture, which shows you the apertura of the opening of the central medullary canal with this bundle of white matter, which is called the fasciculus. So here you can see the two gracile tuberculi, and it's very interesting to see that the gracile tuberculi have there is like a border between the ependymal side of the gracile tubercle and the subarachnoid part of the gracile tubercle. So it's very clear that here there is ependymal and here there is no ependyma. So this is the border, the real border of the ventricle. And laterally to the opening of the central medullary canal, you can see these reddish orange areas. This is the area postrema, and we will talk about the area postrema soon. This is a table showing you that it's possible to see with this approach many of the landmarks within the fourth ventricle, especially those in the inferior triangle. But in the superior triangle, of course, the vision is more limited with this kind of approach. Sometimes we use sodium fluorescein injected in a peripheral vein to highlight something that it's not visible. So, of course, the choroid plexus is visible and it takes the fluorescent sodium, but look at these images. With the fluorescent sodium, we can see also the tiny subependymal vascular network. And the difference using fluorescent sodium and using normal light is very evident with this if you compare these pictures. There are some areas where only the choroid plexus is visible using a fluorescent sodium injection, like the posterior part of the third ventricle, but in other areas, the fluorescent sodium highlights some very important and intriguing areas. I'm talking about the circumventricular organs. We know 7 of them. The median eminence, which is placed at the level of the tuber cinereum. We have always been taught that we can fenestrate the tuber cinereum without any problem because there is no function there. Actually, there is a function there. There is a circumventricular organ, the median eminence. The pineal gland and the neurohypophysis are also considered circumventricular organs, although they are outside from the ventricles. And then the subfornical organ, up here below the fornix, the subcommissural organ just below the posterior commissure, the organum vasculosum lamina terminalis. Also here we have always heard that there is no function in the lamina terminalis, but actually there is a function. There is an circumventricular organ here. And finally, the area postrema at the calamus scriptorius. And with fluorescent sodium injection, it is actually possible to visualize some of these organs. So let's have a look at this video. This is the lateral ventricle, right? Lateral ventricle. We turn on the fluorescent mode. Of course, we can see the choroid plexus because it has no blood-brain barrier. Here we are at the level of the tuber cinereum. Nothing can be seen with normal light, but when we turn on the fluorescent mode, you can see the mammillary bodies and the median eminence. And at the level of the lamina terminalis, this, which is the organum vasculosum lamina terminalis, which is not possible to be seen using normal white light. So since we are using this fluorescent sodium mode, we are trying to pay attention to fenestrate those membranes, trying to reduce the damage on these circumventricular organs. Again, if we navigate inside the through the cerebral aqueduct inside the fourth ventricle, we can turn on again the fluorescent mode. Of course, the choroid plexus appears, and also these 2 leaves departing from the opening of the central medullary canal. These 2 leaves are the area postrema, which is a very fascinating organ controlling vomit and other functions connected to the digestive system. In this patient, we did a reverse navigation from the fourth to the third ventricle, and we were able to see also the subfornical organ below the fornices. So to conclude, flexible endoscopy and endoscopy in general shows the anatomy from a different perspective compared to microsurgery. We were able to count at least 47 anatomical landmarks during our navigations. And sodium fluorescence allows for the visualization of otherwise invisible structures like the circumventricular organs. And in our experience, endoscopy has proven to be superior to microsurgery to describe some specific areas like the cerebral aqueduct anatomy, the inferior triangle of the fourth ventricle, the subependymal vascular network, and some circumventricular organs. Thank you very much.
Thank you, Alberto, for a beautiful presentation. It was a very masterly talk you gave, and we were actually enlightened by the
I
way
cannot
your
hear
flexible
you,
endoscope moves through.
Professor Papa. I don't know why.
Am I audible now?
Yes, we can hear you, Dr.
You are not
Amit.
muted, but I cannot see.
Yeah.
I cannot hear anything.
Dr. Alberto,
okay,
I
maybe
think
I will.
a problem maybe in your microphone
Okay.
or something.
I fixed. I
Yes.
fixed. Perfect. Thank you.
It's okay. Okay, so we'll take the questions at the end, and